Thank you, and thank you for that kind introduction. I'd like to thank Shafiq and the entire team for giving all of us the opportunity to be here. It's already been a wonderful time that we've been having. I think the hospitality that we're seeing in Kuwait is amazing. And before I start, I'd like all of you to give a big hand to the organizing team for such a wonderful show that has been put up. Thanks, Shafiq, and thank you, everyone. I was here about 8 years ago, and I carry very, very fond memories from that time. And what we will be doing is spending the next 3 days going through many of the topics that you've already seen in the program. We've divided these into 5 categories, and in the last day we'll have an audience response system based set of lectures. I'll start off with bone tumors and spend the next 30-35 minutes looking at how we evaluate bone tumors in practice. Now, if you were to go back, look at the list of bone tumors, if you remember something from the residency days, then you have this list and then a few others. These tumors would account for about 90% of all the bone tumors you would see in practice, and then there would be another 20-30 names that would account for the rest of the 10%. Can we have the lights down, please? Thank you. Just put them down. All of these tumors, we can pretty much pick up any standard textbook in radiology and read about them. And you would know what are the radiology findings of an enchondroma, or let's say a giant cell tumor or an osteosarcoma, etc. What we often don't get to hear or understand is how to deal with these lesions when we see them in practice, and that's what I think I will do in the next about half an hour or so. There are certain rules when we look at bone tumors, and one of the ones that we need to understand is that in any patient above the age of 35, irrespective of how strongly, I think we just had our first accident. Are we good? Okay, so in any patient above the age of 35, irrespective of how strongly you might want to make a lovely diagnosis of a primary bone tumor, please remember that the possibility of metastases, plasmacytoma, and lymphoma is much, much more likely, sometimes by a factor of 400:1. So unless there are compelling reasons for calling a lesion in the bone a primary bone tumor above the age of 35, pretty much we should think of Mets, lymphoma, and myeloma before we go on to any of the other diagnoses. So what do we as radiologists need to do? What are the things that we should look at when we're looking at bone tumors and lesions? One of the first things is to identify leave-alone lesions, lesions that occur in the bones but where nothing further needs to be done. Give them a label and inform the orthopedic surgeon not to touch the patient. Right? That's one of the first things and most important things we should do. Then identify lesions that need further evaluation, differentiate benign from aggressive, give context to the CT and the MR when they're done. We look at the x-rays, put everything together, and then try and tell our oncology or orthopedic colleagues what should be the next step. Rule out infection and other mimics, guide a correct biopsy. Either the biopsy needs to be done by us, or we should tell the orthopedic surgeon how to perform the biopsy. And then if it is an aggressive benign lesion or a malignant lesion, stage it well. Perhaps in the evaluation of focal lesions, unlike a lot of other parts of radiology, the plain radiograph still has a key role to play, and that's where we will start with, because that pretty much defines how we would proceed the next or proceed ahead. So if we see a lesion like this, and I think we should have a little bit of a game here If y'all can go with me and try and tell me what lesion this is, I think it would help as well. So when we see something like this, which is straightforward, an osteolytic lesion, epimetaphyseal, extending up to the articular surface, trabeculated. Anybody, what is this? Giant cell tumor. Then we know what this is, and we have seen it on the radiograph, and this will tell us what the next steps are. Or we could have something like this, where we have an expansile bone-forming lesion in the diaphysis of the femur here. Anyone, what would this be? This is a little tough, but if it's a bone-forming lesion, it should be an osteosarcoma. This is an intraosseous low-grade osteosarcoma, but again, very well seen on the radiograph, and this will tell us what next we need to do. But there are situations, especially in the flat bones or sometimes with subtle lesions, where on the radiograph we're not able to see the lesion well, at which time even for identifying the lesion, especially when we suspect it clinically, we need to do a CT or MR. For example, 9-year-old boy has a pain and swelling in the left gluteal region. The radiograph is pretty much normal. Now in this setting, with a normal radiograph, but definitive clinical evidence of a pathology, the next thing we would do is an MR. So on the MR, we can see a permeative lesion, soft tissue component in the gluteal region as well as along the iliacus, a lot of necrosis and enhancement. Anybody, what is this very typical of? Ewing's sarcoma. So here is where the radiograph was normal, but we were able to pick up the pathology using an MR, which helped us identify it, and then of course would tell us what the possibility is, which we would then confirm with a biopsy. Or a situation like this, the patient has pain and swelling along the anterior aspect of the mid-thigh. We're looking at the radiograph and we're not even sure whether there is a distinct pathology. There seems to be some periosteal reaction, perhaps not, perhaps some irregularity, and we don't get much more information on this radiograph. Now, in this situation as well, it's the MR that confirms the presence of a subperiosteal lesion. You can actually see the periosteum lifted up so beautifully by this lesion, which arises from the periosteum here, has some necrosis. And anybody, this is a periosteal osteosarcoma. It's written here anyway. So sometimes I'll fool you. I'll have the diagnosis there in any case to make sure that you all are awake. But this is where the MR tells us that there is a definite lesion, identifies the location, and helps us reach a diagnosis. However, if the lesion is well seen on the radiograph, on the X-ray, then the next thing we need to do is characterize it. And by characterization, we mean trying to figure out whether the lesion is benign or aggressive. To do that, we look at two signs, the zone of transition and the periosteal reaction. The zone of transition is the border zone between the lesion and the normal bone. When the zone of transition is narrow, when it is sharply defined, it tells us that this is a slow-growing benign lesion. Anyone, what do you think this is? An osteolytic lesion, metaphyseal, extends up to the physeal plate, trabeculated, and a narrow zone of transition. In an immature skeleton, the most likely possibility would be an aneurysmal bone cyst. You could also get pediatric giant cell tumors that can do the same thing. On the other hand, we have a wide zone of transition, looks like a permeative pattern, where we actually do not see a defined border zone between the abnormal bone and the normal bone. So when we have a diffuse wide zone of transition between normal and abnormal, that invariably tells us that we're dealing with an aggressive lesion. Osteomyelitis could do that, but otherwise it implies that this is a malignant tumor. Anyone, what's the most likely possibility? Young patient, permeative lesion, long bone. It's most likely a Ewing's sarcoma, or could be an osteosarcoma. So this is how the zone of transition helps us define benign from malignant. We can go one step further. If we find that the narrow zone of transition also has a sclerotic rim that further reinforces that this is a really slow growing benign lesion. So the sclerotic rim actually gives us that much more confidence of the benignity of the lesion. Any one young patient, immature skeleton, cortex-based lesion, looks like a cookie bite. Someone's, eaten away something from the posterior cortex of the tibia, and this is typical of. This is an unusual, uncommon tumor. This is a chondromyxoid fibroma. And especially in the Indian subcontinent and in many other parts of the developing world, we see a sclerotic rim, but associated with that, we see ill-defined sclerosis in the adjacent bone. This sclerosis is a reaction to the abnormal process, a slow-growing process that is happening here. If we see a sclerotic rim, that tells us this is a benign lesion, along with surrounding ill-defined sclerosis as a reactive phenomenon. We should also be thinking of anyone? Osteomyelitis, perhaps of tuberculous etiology. The next thing we look at is the periosteal reaction. When we have a well-defined cortical thickening, when we have layered thick buttressing or periosteal reaction, this tells us that this is a benign lesion, as in this cortex-based diaphyseal lesion in an immature skeleton that is typical of a non-ossifying fibroma. This is more like a giant non-ossifying fibroma. On the other hand, when we have irregular, broken, dirty-looking periosteal reaction like we see here, this tells us that this is a malignant tumor, as we would see in this patient with an osteosarcoma. Of course, these kind of textbook pictures of a sunray appearance with a Codman triangle, we're also actually seeing new bone formation within, not something that we see very often these days, but when we do, then these are typical features that tell us that we're again dealing with a malignant tumor, and in this case, again, this is an osteosarcoma. So, both the periosteal reaction and the zone of transition taken together help us differentiate a benign from an aggressive / malignant lesion. To repeat, when we have a narrow zone of transition with or without a sclerotic rim, or a thick, regular, benign looking periosteal reaction, then we know that we're dealing with benign lesions. If we have a wide zone of transition, we have irregular, dirty periosteal reaction, or we have a sunray appearance, etc., then we're dealing with a malignant lesion. At the same time, it's a good idea to look inside the lesion, because if the lesion has material within that allows us to differentiate the matrix, whether it's osteoid or chondroid or fibrous, then that gives us a further clue as to what the lesion might be. So here, for example, we see osteoid matrix, and one way of remembering osteoid matrix is to ask ourselves whether there is new bone formation. The phrase new bone formation is better to use than the term osteoids. If we see new bone formation like we see here, it implies that it is one of these tumors that forms new bones. It could be an osteoid osteoma, an osteoblastoma, osteoma, or an osteosarcoma. Now, coupled with the fact that we have a wide zone of transition, irregular periosteal reaction, which tells us it's an aggressive lesion that has new bone formation, then what is the diagnosis? This is an osteosarcoma. Right. Then we have the chondroid matrix. So here we see this fluffy, cloudy appearance. Again, there is stuff inside the lesion that gives us a clue as to what this might be. When we see this cloudy, fluffy appearance, this tells us it's a chondroid matrix. And again, we would be looking at these cartilage-forming tumors such as chondroblastoma and chondroma. And osteochondroma is slightly different, and I'll show that to you in a minute. And then if it's malignant, it would be a chondrosarcoma. So here we have a benign lesion, narrow zone of transition, no periosteal reaction in the phalanx. So when we see this, it tells us that this is a benign cartilage containing tumor in the phalanx that is most commonly seen with an enchondroma. If we have a rings and arcs appearance, and here you can see an appearance of multiple whorls and rings all across the lesion, which is again what we see with cartilage tumors. And again, if in this case, as we see, there's irregularity, a lot of shagginess along the margins, that tells us that we're dealing with a cartilage tumor that is aggressive. And an aggressive cartilage tumor becomes a chondrosarcoma. In this case, we can see that there's a broad base to the bone, and you can actually make a comment saying that this is likely an osteochondroma that has gone bad and undergone malignant transformation into a chondrosarcoma. Then we may not see a matrix. You may not see any osteoid or chondroid stuff within, in which case we start looking for entities like simple bone cyst, giant cell tumor, aneurysmal bone cyst, non-ossifying fibroma, etc. So here we see a lesion that has a narrow zone of transition. There's no periosteal reaction, so it's a benign lesion. It's in the mid-humerus in an immature skeleton with no matrix. This is extremely typical of a simple bone cyst. In fact, if somebody were to call you and tell you, I've got a 15-year-old patient with a cystic or an osteolytic lesion in the mid-humerus, even without looking at the radiograph, sometimes you should be able to say that this is most likely a simple bone cyst. A ground glass matrix looks like finely ground glass that we often see in various religious institutions like mosques and churches, where they make fine paintings on them. And this is what ground glass looks like. When we see a lesion with a ground glass appearance that has a narrow zone of transition here, we know that it's a benign fibrous containing lesion that is most commonly seen with fibrous dysplasia. Now, in this setting, where we're looking at the matrix, we get a set of lesions that also has a trabeculated appearance. The vast majority of lesions with a trabeculated appearance will also have a narrow zone of transition, and they will have benign looking periosteal reaction. These are the entities we should look for or think about when we see trabeculated lesions. That's giant cell tumor, ABC, desmoplastic fibroma, and a giant non-ossifying fibroma. Within this context, so when we see a trabeculated lesion like this, epimetaphyseal reaching up to the articular surface, narrow zone of transition, it tells us that we're dealing with a benign lesion, most likely a giant cell tumor. When we look at the cross-sectional imaging with MR and CT, we find something quite interesting. If you look at the MR here, you actually don't see any abnormal trabeculae. When we look at the CT here, there are no abnormal trabeculae, unlike that you're seeing on the radiograph. This is a pseudo-trabeculated lesion. It looks like it's heavily abnormally trabeculated, but there are no abnormal trabeculae on the CT or the MR. This is a feature that's extremely characteristic of a giant cell tumor. The reason we get the pseudotrabeculated appearance is because of the unusual amount of scalloping that occurs along the endosteum, that on a projection, AP or a lateral image, will give rise to an appearance of a trabeculated lesion. So this is a point to remember. Trabeculated, benign looking lesion on a radiograph, but not abnormally trabeculated on CT or MR, think of a giant cell tumor. Abnormal woven bone, as we see here, with a little bit of thickening of the cortex, we see that really well here, is typical of Paget's disease. Anyone, an osteolytic lesion in the cortex with benign looking thick periosteal reaction and sclerosis, what's the most likely possibility? This is an osteoid osteoma. And if it is a little larger or in the spine involving the posterior elements, then we often think of an osteoblastoma. So that's essentially looking at the matrix. So once we've decided benign versus malignant on the basis of the zone of transition and the periosteal reaction, we then look inside the lesion If we find an osteoid matrix, then we have a list of lesions that present with an osteoid matrix, benign or malignant, the same with chondroid, the same with a ground glass appearance. Then we have trabeculated lesions, and we have a list of short differentials. We've learned about a giant cell tumor that actually is not a trabeculated lesion, Paget's that has its own unusual matrix appearance, and an osteoid osteoma that by itself is a tumor that occurs in a very distinctive manner. Now, all these lesions, every osteolytic or osteosclerotic lesion that is solitary, especially in a young patient, almost always gets an MR or a CT done. One of the reasons for doing this is to stage a lesion, especially if we're going to operate ahead, but also to try and get more information about what the lesion might be. The traditional teaching is that MR and CT do not allow characterization, do not give us a sense of what the histopathology might be, but that's not entirely true. And we look at a set of lesions where the MR appearance also pretty much tells us what the lesion might be. So when we see a mid-humerus cystic lesion containing fluid with a fallen fragment of which has occurred following the fracture with absolutely no enhancement, this tells us that we're dealing with a cyst, and a cyst in the humerus would be a simple bone cyst, and we can see that on the radiograph very well, including the fallen fragment sign of the simple bone cyst. Or when we see fat within the lesion, this is an osteolytic lesion in the calcaneum. It has fat within, it has a central ossific nucleus, which is also very, very typical. The presence of fat in a benign osteolytic lesion, and we see that very well here with a narrow zone of transition and no periosteal reaction, tells us that this is an intraosseous lipoma. When we see low signal on all sequences, so that's a T1, that's a T2, we see lobulated low signal on all sequences, that tells us that we're dealing with a fibrous tumor. And when we see a cortex-based fibrous tumor on MR in a young patient, this is again very typical of a non-ossifying fibroma. Then we see a similar lesion, low signal, but it's metaphyseal, extending up to the epiphysis, but does not reach the articular surface. Again, low signal tells us it's fibrous. This is in a larger bone, does not reach the articular surface, hence it's not a giant cell tumor, and this is typical of an entity called a desmoplastic fibroma. Pretty much behaves like a non-ossifying fibroma, but because it occurs in a larger bone, has to be treated because of risk of fracture. And that's what a desmoplastic fibroma looks like. It's a finely trabeculated lesion with a thick sclerotic rim, but does not reach up to the articular surface. This is another tumor pattern. We have lobulated, a lobulated appearance with very fine septae on a T2 weighted image. And this is very typical of a specific tumor type, and this is very typical of a chondroid matrix. This tells us that we're dealing with a cartilage tumor. Then we look at the radiograph and we marry the two together. We have a cartilage tumor that's greater than 5 centimeters long in the long bone with a little bit of endosteal scalloping on the radiograph. This tells us that we're dealing with a potentially aggressive cartilage tumor. The aggressive cartilage tumor is one name, and that is a Kandra Sarcoma. So we are able to pick up even a cartilage matrix most of the times. Here, for example, is an osteochondroma where we see the marrow in contiguity, and then we look at the cartilage cap, which is extremely thin, on a T2 weighted or a stir image, and this is the cap that we need to evaluate to figure out whether there has been malignant transformation or not. And that's the osteochondroma on the radiograph that we've been looking at on the MR. And I showed you this example before where we had the rings and arcs appearance with a very, very dirty picture telling us that this is a chondrosarcoma, but you can see what it looks like on the MR. It's lobulated, hyperintense with septae. This is very typical of cartilage, but it's very thick cartilage, and it tells us that the cartilage cap has now essentially become malignant, or the entire lesion has become malignant, and that this is now a chondrosarcoma. Then we have this sign where we're seeing fluid levels across the entire lesion. So when we see fluid levels like this, it tells us that we're dealing with an aneurysmal bone cyst. Of course, we have to compare this on the radiograph with the lesion that shows a narrow zone of transition. There is no periosteal reaction. So a benign lesion on the X-ray with fluid levels on the MRI is very typical of an aneurysmal bone cyst. On the other hand, here is another patient who has large fluid levels, and we might be tempted to call this an aneurysmal bone cyst. But when we see this on the radiograph, we see that there is an aggressive lesion with new bone formation here, and this basically tells us that it's an aggressive malignant tumor with fluid levels, which is what we get with a telangiectatic osteosarcoma. There are other things that help us with the diagnosis, and this would be the location, the age, the sex, etc. For example, an epiphyseal benign lesion with a narrow zone of transition is a chondroblastoma. An epimetaphyseal lesion that extends up to the articular surface is a giant cell tumor. A phalangeal benign tumor in almost all cases is an enchondroma. A tibial lesion that is cortical with a mixed osteolytic sclerotic appearance with bowing is osteofibrous dysplasia. An osteolytic lesion with a narrow zone of transition, metadiaphyseal, is a non-ossifying fibroma. A mid-humerus lesion in an immature skeleton, benign looking, is almost always a simple bone cyst. And a juxtacortical bone-forming lesion like this almost always is a parosteal osteosarcoma. So we get a lot of information from the radiograph and the MR and CT looking at all of these parameters that we need to evaluate. So the zone of transition periosteal reaction is benign versus malignant. Looking at the lesion characteristics on the X-ray, CT or MR would tell us whether it's osteoid, chondroid, etc. And then looking at the location and certain other features would help tell us what we're dealing with. I saw the 5-minute sign, but I've been timing as well, so I have 8 minutes. I'm going to take those 8 minutes, right? And these are leave alone signs, and these are signs that we look at. Now, all of this helps us identify those lesions where we can actually tell the orthopedic surgeon or the treating doctor that do not do anything further. For example, a non-ossifying fibroma that we see here, nothing needs to be done. You have to leave this lesion alone and not treat it. Or for that matter, an enchondroma that occurs within the phalanx needs to be left alone unless it has fractured, in which case it's the fracture part that needs to be treated. So as radiologists, we can have a sense of the lesions that can be left alone, and we can advise our colleagues about them. The next thing we would do is guide biopsies, and there are certain rules there. We do true cut or J needle biopsies. We do not ever do fine needle aspiration cytologies because we do need a lot more information when we're getting material out of these lesions. And most importantly, we have to do the biopsy in the plane along which the surgical incision is going to be taken. So we need to have a little sense of where the surgeon is going to operate from and make sure that if the lesion is here, then we take, or the biopsy needle actually goes along this plane and not along this plane or this plane, etc. The reason is that if it's a benign, aggressive, or a malignant tumor, there is a chance of seeding along the biopsy tract. And if, for example, we've put a needle in this plane, the surgeon has to excise the biopsy tract, and this makes the surgery that much more difficult. So there is a rule for biopsying both soft tissue as well as bone tumors, and that is the needle, the biopsy needle has to be along the plane of the expected incision of the surgery. And this is what we do in our practice. We use an 11 gauge Cook needle through which we insert an 18 gauge gun and take material out. If the lesion turns out to be benign, aggressive or malignant, then we have to stage it at the same time. And the principles of staging are very simple. We look at the extent of the lesion, neurovascular bundle involvement, and joint involvement. These are the most important things that we have to look at. When we are looking at staging, since today the mantra that all the orthopedic oncologists have is limb salvage surgery, what we need to really do is give them the true extent of the lesion. So a lesion like this, if they were to do limb salvage, they would need to know where the normal bone is, because that's where they will take the cut into which they have to place the implant. So we need to tell them that this is where the cut is. We have to tell them what is the length of the tumor, both within the marrow but also in terms of the subperiosteal component. So when they take the cut in the bone, it won't be here, but it's going to be above, about 1 centimeter or 2 centimeters above where the subperiosteal component ends, and that becomes important. And if in all of the staging that we do for malignant or benign aggressive tumors, there's one thing that we get right or need to get right, it is the length of the lesion, because this pretty much is the most important thing that the orthopedic oncologist wants from us. The other is to mention whether there is transphyseal spread or not. Our traditional textbooks keep telling us that osteosarcomas, etc., do not cross the physeal plate. Well, we all know that it's not really true. Most of the tumors cross the physeal plate and extend up to the epiphyseal margin. The next thing they would need to know is whether there is joint involvement, because if there is, then limb salvage is very difficult. They may either have to disarticulate or actually perform an amputation. And in this case, we can see that the tumor extends into the joint, encasing the cruciate ligaments, and that tells us that this is a very, very difficult case for the orthopedic surgeons to treat. To look at neurovascular bundle involvement, the T2 axial is perhaps the best sequence. We can see the tumor and its relationship to the neurovascular bundles very well. In this case, there is no involvement. But in this case, we can see that the neurovascular bundles are encased, which makes surgery very difficult, and in some situations tells us that we need to amputate the limb. Most of the bone tumors that we evaluate, on MR, we do a dynamic contrast study. And on the dynamic contrast study, we get an arterial phase as well, on which we can see what the status of the arteries and veins is. And we can see that here, that the arteries involved, the veins involved, there's complete involvement of the popliteal neurovascular bundle. That again tells us that there's going to be a lot of problems with the surgery in this case. And lastly, when we're staging a lesion, we need to take wide field of view images. And these days, typically we do either a whole lower limb or a whole upper limb as either a preliminary sequence or at the end to look for skip lesions. The commonest bone where the skip lesion occurs is the same bone. And you can see here a long segment osteosarcoma that perhaps could be treated with limb salvage by taking a cut here and putting a long implant inside. But there's a skip lesion that's seen in the proximal diaphysis, which makes any kind of limb salvage very difficult. You also get in the limbs where we have two bones together, like the leg or the forearm, you can get skip lesions in the opposite bone. So here we have a fibular osteosarcoma, and we see a skip lesion within the tibia. Again, completely changes the way that we deal with these patients, and more often than not, what it means is that the patient will only benefit from palliation, and that curative treatment is going to be unlikely to help. So as far as staging is concerned, these are the 5 points that we need to look at. So before I end, a couple of rules that I believe we need to follow very, very strictly and strongly. There is a tendency when as radiologists we look at MRs and CTs to report the MRs and CTs in isolation of the radiographs when we're looking at bone tumors. Believe me, this always leads to problems. This is a colleague of mine a very, very good radiologist who reported this lesion in the diaphysis of a 9-year-old as a Ewing's sarcoma. And that's because he saw a lesion that was within the diaphysis. He thought this was a little permeative, and he called it that. The orthopedic oncologist was not convinced, came to me. This was the MR, the T2 weighted axial that he had, and said, you know, I'm not convinced this is Ewing's, and before I put a needle inside, can we do anything else? And I said, let's do a CT. And on the CT, you can see that the cortex is actually split, and that this is a cortex-based lesion. That's the marrow cavity that is displaced. But none of these, neither the MR nor the CT, gives us a true understanding of what the lesion is. That's the lesion. Nobody had bothered to look at the radiograph. This is a lesion with a sclerotic rim. It's got a thick buttressing. We've already seen this before. It's cortex-based, and this is very classic of a giant non-ossifying fibroma or an osteofibrous dysplasia. Nothing really needs to be done unless the patient is symptomatic. So you're going from a Ewing sarcoma to an osteofibrous dysplasia or a non-ossifying fibroma, two ends, two completely different ends, and you can think what the parents would be going through getting a diagnosis of a Ewing sarcoma. And lastly, again to repeat that in any patient above the age of 35, irrespective of what I've said in the last 35 odd minutes, think of Mets, plasmacytoma, and lymphoma as the first diagnosis before jumping to a primary bone tumor. Thank you for your attention.